Okay, please join me in welcoming Dr. Jennifer Newitt, a clinical instructor at University of Pittsburgh Medical Center, otherwise known as UPMC here, and postdoctoral scholar at the University of Pittsburgh. Dr. Newitt specializes in pulmonary and critical care with a focus on non-invasive ventilation for patients with neuromuscular diseases. She will now be leading the session, Breathing Matters Acute Adult Pulmonary Care. Got my mouth full.
Thank you. All right. Thank you guys for joining. And I think we're being recorded, so hopefully other people will be able to listen if they're joining a different session. Feel free, this is like for you guys, so if there's any questions, interrupt at any time at the end. It's really hopefully for you guys to get the most out of it. So I don't have any disclosures or any conflicts of interest. My hope for today is to go through sort of what we see as acute respiratory issues that come up with RYR1 and other neuromuscular related diseases, sort of talk about how we assess the degree of illness and manage acute symptoms, talk about some of the challenges and some tips and tricks for patient advocating when you're in this situation. So first, let's just start with sort of talking about acute respiratory issues. So many things that may be common to you guys, common things that cause breathing-related trouble in anyone, but maybe worsened in somebody who has any underlying muscle weakness. Start with your common colds, viral infections. Nowadays, there's COVID again flying around, flu. Nasal congestion, that can just be allergies, even in some people, that creates a lot of symptoms and makes somebody tired. Increasing saliva in the mouth or trouble with swallowing that can lead to some aspiration of food or mucus and affect breathing. Pneumonia that can be both viral related or can be from bacteria that needs different degrees of treatment. Some people get a lot of mucus that they feel like plugs up their lungs or causes trouble breathing, and then leads to sort of malnutrition, not feeling like eating, and then that makes us overall weaker. So symptoms that people often describe or know when you're sick, common things that you guys think of, I think, is feeling short of breath, someone noticing, working a little bit harder to breathe, having a cough, feeling more tired, decreased appetite. Some people describe chest pain that comes along with having a pneumonia. We don't actually have nerves in our lungs, but around the chest, there are a lot of nerves. If you cough too much, it gets sore, your muscles hurt. If anything's touching the edge of the chest wall, it can cause some irritation and cause pain. You get too sick, you don't breathe deep enough, your carbon dioxide can get higher, can cause some confusion, can cause headaches. So these are just sort of general things I think we all think of when we get sick with a respiratory infection that could come up. When I think of sort of the overall evolution of respiratory function in people with muscle disease, at baseline, normal function is normal breathing. As we get a little bit weaker in our muscles, the REM sleep, which is the deep dreaming sleep where all the muscles in the body are actually paralyzed except the diaphragm, we can develop some trouble with breathing in that time, with lower oxygen, not taking as deep a breath. As our respiratory muscle function, what we call the vital capacity, the ability to take a big breath in, gets lower, then we have trouble during both the REM sleep and the lighter stages of sleep. So people will comment they wake up a lot and they don't know necessarily why they're waking up. So sleep is disrupted, more tired, maybe some snoring type symptoms. And ultimately, as muscles weaken, we lead to trouble in the day where people feel short of breath all day long. At any point, any sort of respiratory infection, virus, chest cold, can sort of hasten this process. So we can go from normal breathing to being in trouble in the day just from an infection if we don't pick it up quick enough and manage the symptoms. I think the main thing that drives a lot of this with respiratory illness, whether it's virus or bacteria, is we start in RYR1 and other muscle diseases with impaired respiratory muscle strength to some degree. And when we get sick, the muscles get weaker and are more susceptible, which leads to decreased ability to cough. So the mucus builds up in our chest, and that creates a lot of room for pulmonary trouble, worsening infections, hard to treat pneumonias, and so forth. So the goal is to try to stop the problem before it becomes a bigger problem, right? So always the question is trying to decide whether or not to go to the hospital, when to call the doctor, what testing do you need, and that's a challenging one. Most of us like to say, oh, I'll be fine, it's just allergies, or it'll pass. I think we all have to know ourselves a little bit, and so if you know that you're someone who gets sick easier and rebounds a lot slower, then calling sooner is important, trying to get ahead of the game, and we'll talk a little bit about the assessment and the management next. I don't want to encourage people to go to the hospital anytime they sneeze or cough, but I think if you feel something coming on and not getting better, a low-grade fever, knowing for some people the heart rate goes up a little bit, or you're just generally more tired, each of us sort of has our own signals, and knowing when we need help and not ignoring them is the key. So let's talk about how we assess potential respiratory illness. So first and foremost, I think, is vital signs. And nowadays I do a lot of telemedicine visits, and people have at home blood pressure monitors, pulse oxes that can tell you your heart rate or your oxygen level, fever, so thermometer. So if any of these things are off, you have just a little cough, but your temperature's normal, your heart rate's normal, your oxygen is greater than 95% if that's your baseline, you're probably okay at the moment. Monitoring these things for changes kind of helps, and it can be done at home pretty simply, can help you to know something is brewing. So a lot of times the heart rate, if it's normally 90, maybe 100 or 110 before you really feel super sick. It's sort of your body's way of knowing something is brewing. In the setting of fever, the heart rate should always go up. The oxygen is the other key thing that helps in muscle weakness. So for people who have bad lung disease within their lung tissue, so asthma, COPD, scarring of the lungs, or any history of prior lung tissue problems, the oxygen level may not be perfectly normal. But if you have never had a lung problem, you just have muscle disease, we would expect the oxygen level to be 95 or greater as long as you're taking big breaths. And so one of the things I encourage my patients to do is if they don't feel right, they feel funny, to check their oxygen and see where it is. The little pulse oxes come from any pharmacy, Amazon, etc., for $10 or $15. And that's kind of a good marker of something might be happening from a respiratory standpoint if you're not feeling well. We look at lab studies, so looking for white blood cell counts, anything that's showing signs of infection. If the electrolytes are thrown off, that may be a sign that your body isn't processing things as well. We can do tests for viruses, so a lot of us now have COVID tests. There's also a commercially available flu, COVID, and RSV test that you can do at home that helps to pick up, is this the virus that's causing the problem? Once you get in touch with the doctor or urgent care or going to the hospital, we have imaging that we look at to try to help see whether there is a bigger problem in the chest with either chest x-rays or CAT scans. Hopefully this isn't something you need all the time, but is available if we think somebody is sick and we really need to make sure that we're not missing something. We can do respiratory muscle strength testing as simply as sitting here, handing you something and having you breathe in to see how well the muscles are. A lot of people will have, can just buy from Amazon, if you've ever been in the hospital, what we call an incentive spirometer. I'll show one a little bit later, but the little ball just goes up and down, and if you know when I'm well, I can get it to 500, 1,000. You're not feeling well and now it's only going to 300 or 400, that's a sign that your muscles are a little bit weaker. So something you can measure at home as sort of a predictor that I might be getting a little bit weaker. We can also do cough strength testing, which I'll show you in a little bit, but measuring how strong your cough is. I don't want to do it into the microphone, it might be too loud for you guys, but normal cough we'll talk about is a big breath in, a loud cough, versus as you get weaker, we sometimes hear more of a and we don't have it coming from down deep. And that makes a big difference in terms of clearing mucus, something you can pick up on at home that may be a sign it's time for me to reach out to someone. To give you an idea of sort of what we see on chest x-ray, this is a very normal chest x-ray, and they're always backwards. So this is the right lung, and this is the left lung. To sort of orient you, if you've never looked at one, this is the spine coming down the middle. The heart sits here, and then all these white lines are the ribs. So bones are white and air is black. So we like to see lots of black in both sides of the lungs. The little white in between is blood vessels and tissue, which we need to be able to take the oxygen in. This is the diaphragm in a perfect kind of concave shape. And usually if someone can open their lungs and take a big breath, we can count at least 6 or more ribs. So I count 1, 2, 3, 4, 5, 6, 7, 8-ish ribs on that one. So this is an example of normal. And then to show you some more abnormal, we see when people get weaker, what can result from weaker muscles is our posture can become sort of curved from a front to back standpoint, what we call kyphosis. And you see some people, when they're really kyphotic, they end up sort of really bent over, and the curve often happens up at the neck. Sort of colloquially, we call it like a hunchback kind of position. If somebody has bad muscle weakness on the lateral ways, this is scoliosis, the spine becomes in an S shape. And you can see in this case, the lungs are very sort of shifted and smaller, and the muscles are more stretched out. It's harder to get a big breath. It's harder to cough. And so in both of these cases, you end up just a little more susceptible to being sick. People with muscle weakness may just have decreased ability to take a big breath in. In this case, it's just one side. So we can only count 1, 2, 3, 4, 5 ribs. The other side is a little bit more expanded, but still probably less air than this normal one. So these are people at home living normal, not sick, but just muscular abnormalities that causes them to be twisted in one way or not be able to inflate the lungs all the way, and leaves a predisposition to being sicker if we get a pneumonia, we get a virus, and we have trouble getting the mucus out. What it looks like when you get pneumonia, the top one is showing these whiter areas right here where the arrows are. If you can compare to this one, there's less. And this is more of what we think of as sort of what an aspiration picture looks like. So if someone is swallowing, whether it's saliva, food, drink, and it's accidentally some sneaking down into the lungs, it usually follows gravity and ends up in the bases. And so we can see sort of this white collapsing pneumonia area in the base of both lungs. Versus this one where the side looks good, but over here we have this white sort of circular opacity is the medical word we use for it, that is probably representing a pneumonia, something that's infected that's in there that's just getting that one part of the lung. So this is what we look for from a medical standpoint when we get a chest x-ray on somebody, and this can be done as an outpatient or as an inpatient. Any questions on this so far? Okay. So let's talk about how do we cough, because that's really our mainstay of what keeps us from getting sick. So before I show you guys, if you all sort of think and practice the cough, see what you do. So first step in, we have to have some sort of irritation that we want to get rid of, but then we have to take a big breath. So we have to open up our lungs. This is the diaphragm, this big muscle here. And it moves down, and by moving down, our lungs fill up with air, the airway opens, and lots of air comes rushing in. So step one is big inhale, right? The next step, you sort of hear me, I stop, and the airway has to close for a very few milliseconds, enough that you can get your muscles to start to push, so that then we can have the expulsion phase or the cough out phase where the diaphragm gets moved back up, the chest muscles are pushing in, and we bring mucus out. So if anywhere along the way we have trouble, our cough becomes ineffective. So if we have trouble going in, then it's hard to get the cough out. If you have trouble being able to keep your airway closed, it's hard to cough out. So we can have trouble at any step. We can measure cough strength by using a peak flow meter. So we have some that have a mask on them, some that you make your lips seal around. These are things that we can order as a doctor. You can get on Amazon at the pharmacy that just you blow into. So in these, where we measure, what we do is we take a big breath in and we blow. And in this case, this little red thing goes moving. And in here, there's a little ball that goes moving. And we measure how many liters per minute based on that number it goes is our cough strength. And anything greater than, to keep it easy, I say 350, but by the literature, it's 360, is considered normal. Anything that's like half of that, 150 to 250, keeping the numbers easier to remember, is impaired. And anything less than that is insufficient, meaning you're not going to be able to clear any mucus and you're going to be at risk for getting much sicker. Someone, when they're well, may sit here and be in the normal range, and with a little bit of weakness from the illness, the virus and pneumonia, may become an impaired or an insufficient cough that really is ineffective and needs some help to make it stronger. So how do we manage these symptoms? And how do we, if somebody gets sick, then what do we do? So we have the opportunity to use breathing support. So oxygen is always the question. Notice I didn't list it there. In people who are weak, we want to first make sure we're giving a big breath in to make sure that we get rid of the carbon dioxide, which is the problem that makes us sicker and makes us worse. If we just put oxygen on without helping get a big breath, we can actually make the problem worse. So step one in going to the ER, and tips for advocating later, is to know that the first line answer is not always oxygen. It's to make sure you're getting a big breath, what we call ventilating. And we do that with positive pressure. Can be with a mask or a mouthpiece. For people who are really sick, they can end up with a breathing tube, what we call an endotracheal tube, and on a ventilator for a short period of time to help make sure their lungs are opening and expanding. We want to do secretion management things, and we want to make sure that we have good nutrition, because weak muscles don't like to be starved. So what does positive pressure do? It helps improve your oxygen by getting you a bigger breath and not letting you do all the work. So think of if you were to lift something heavy. You can kind of get it up, but then you want to drop it right away. But if someone's on either side and can kind of spot you or aid you, you can lift it all the way up. Same thing with the diaphragm, the breathing muscles. So they are trying to push down to get as much air, but if they're weaker or you're using them too frequently, breathing fast, then they can run out of their energy and get weaker, and so we need to help them, and we help them by pushing the air in with positive pressure. In some cases, we just do it with sleep at night. Other times, we need it all day long. So some people, this is baseline at home, but if you're somebody who doesn't use these therapies at home, then this is something we can do acutely in the setting of a respiratory illness. If you use it at home, then sometimes we have to up the settings to get you a little bit more support when you're in the setting of a respiratory acute illness. The thing we know is that using the non-invasive ventilation, the BiPAP on the acute need, really reduces the need to have to be intubated with a breathing tube, and it decreases hospital length of stay and actually improves length of life. So there's lots of benefits to it. What this chart is just showing is your oxygen level without positive pressure, and it goes up dramatically when you use positive pressure. And the carbon dioxide level that's high, we put on some positive pressure and it comes down to normal. So we improve the work of breathing, we improve how our mechanics of our chest are moving, we improve oxygen, and we get rid of carbon dioxide, which is improving ventilation. So a lot of people ask me, what happens if I need to be intubated? And I don't know if this is something familiar to any of you guys in the room, but a lot of patients I see are scared to death for anesthesia, for surgery. What if I get sick and I need to be on a ventilator, which is scary to everyone, but I think for people with muscle weakness, it's built up to to be a scarier thing. Obviously, we want to try to avoid it as much as possible, but there are many cases that we can't avoid it. I would say, as a pulmonary doctor who specializes in taking care of people with muscle disease, it's not the end of the world. We can get people off the ventilator, and there's research, I'll show you some data that from one study and the success rate. The key is to know how to do it, and to remember that people with muscle disease are not the same as somebody without muscle disease. So we can't take a cookie cutter approach. We have to do it with a mindset that someone's muscles are weaker and they're going to be needed to treat a little bit different. So I would say we always proceed with caution, but if you need to be intubated for some respiratory illness, to get through the pneumonia, to get through the flu, my hope is that we can get people through it. So this study is from 2010. It actually was done in New Jersey by John Bach, who's one of the sort of fathers of non-invasive ventilation and neuromuscular disease. And what he did was he took 157 patients who were deemed to be unable to get off the ventilator, and transferred them in, people who didn't ever want to have a tracheostomy tube. And he talked about how we can get you to be on your own breathing without any long-term difficulty of tracheostomy or saying there's nothing we can do. And the key to success was making sure the infection is better. The fever's gone. Your body's not trying to be amped up, trying to beat the fever. The white blood cell count, a sign of infection, is normal. The chest x-ray has to be pretty normal or on its way to be normal. Air leak just means that your vocal cords and your upper airway is not swollen, which is the case for anybody before we would take them off the ventilator. You have to be so weak, you need a lot of support to breathe. Awake and cooperative, meaning you understand what's going on and you're not on any sedation. You have to have a normal carbon dioxide and a normal oxygen level that if it drops, we can do some suctioning, or this is a manually assisted cough to make it stronger. And if you meet all these criteria and we are able to do some cough assist, which we'll talk about in a little bit, then we can, he actually showed in this study, and I agree with it in my experience, we are able to pull out that breathing tube and use BiPAP for a short term. And he found in this study greater than 95% success in getting people off the ventilator. So the tricky part is following this sort of criteria is not something that is standard to what the average ICU patient who needs to be on the ventilator goes through. And so this is sort of a niche, just something specific to the neuromuscular world. But if managed right and knowledge is there, it can be done successfully. So I hope you hear that if you ever find yourself in this situation, make sure that whoever is going to advocate for you is aware that this is possible, and they just need to make sure the person managing your care or your loved one's care has the information and the knowledge. And then beyond helping with the breathing, we really need to focus on how we get rid of the mucus that comes when we're sick and we're not able to cough. So lots of things we'll go through. So the first set are really what we think of as hyperinflation, meaning opening up the lungs. So this was the incentive spirometer. This is just one of many designs and companies that I was mentioning. So there's a tube that you are going to inhale with, and as you suck in, this blue ball is going to rise, and it helps to figure out how much air you can pull in, tells us a little bit about your lung strength. The thing on the side is to make sure you do it nice and slow and don't go like that. That's cheating. You have to nice and slow pull it in, which is harder to do. So this is one way that you can, at home, even when you're well, maintain your breath size and your lung volume. In the hospital, if you're too weak in a period of sickness to be able to do this or to seal around it, then we can do something that's called easy PAP, which is easy and then positive pressure. And this is just a little device that they have you put in your mouth, and it actually blows the pressure in while you breathe to help get your lungs open without, it's sort of short term, 5-10 minutes rather than a mask on your face. We have something called a flutter valve, and these are different varieties of brands. The concept of flutter valve is there's something inside. Some of them have a metal ball, some of them have a plastic piece, and they vibrate when you blow on them. So you're going to take a big breath and blow, and as it vibrates, that sort of goes down your airways and helps loosen up the mucus so that you can cough it up better. So both the flutter valves and incentive spirometer are things that can easily be bought on Amazon at a pharmacy, that you can do on an everyday basis, or have if you start to feel like you're getting a cold and have a lot of mucus, relatively cheaply, and it takes 5 minutes total to do these exercises. Are you guys familiar with any of this?
Yeah, the hospital we used to call those
Pickles. Yeah. The pickle, yep. You got it. I haven't actually seen around here, we don't have the pickle version anymore. We have a different one, but they all work the same way. Yeah. And then we have, more specific therapy, so chest vest that we can use both at home and in the hospital if someone's acutely sick, that just shakes you to loosen up the mucus to be able to help cough it out. Some people, and a lot of times with kids when they're smaller, we start with just chest physical therapy. So it's just sort of you can use a cup, you can put your hand in a cup and sort of beating on different parts of the chest to try to loosen up the mucus. Then it has to be coughed up. So notice, in this case, you're blowing and loosening, but you have to still cough it up. Same thing here, the chest vest shakes, but you have to cough it up, and the chest PT, you have to cough it up. Metaneb is another device that's in the hospital that does this. You have a mouthpiece, can also run it through a BiPAP machine where it blows in for a minute or two, whatever we set it to, and then it sort of makes the air shake to help with this loosening secretions up. Can be done at the same time we put medicines in. So sometimes we put breathing treatments like albuterol to help open the lungs if there's a lot of inflammation, irritation. We sometimes use hypertonic or salt water. The salt water brings more water into the mucus to make it thinner, easier to cough up. And these can be done together. Again, we're thinning, we're shaking. You still have to, as the person, be able to cough it up. So if your cough is weak, how do we get it out? And this is sort of one of the mainstay treatments for anybody who has weak muscles, is not able, when we talked about coughing, to do a good cough or has an insufficient cough. And it's a cough assist device, also known as an insufflator, big breath in, exsufflator, air coming out. These are the 3 models that currently exist on the market that you could have at home or we have in the hospital. And the concept is it delivers a big breath and then it turns around and has a negative force that sucks out. So as you cough, it's the assist to your cough. It's helping to pull the secretions out. And it's the only thing we have of all that I talked about that actually brings mucus out versus loosens it. So it can be done with a mask held to the face. If someone's able, they can hold their own. If they have weakness, someone can hold it for them. Or a mouthpiece you hold between your lips can be attached to a tracheostomy tube or to an endotracheal tube for someone in the ICU. And essentially you go inhale, then exhale, and then it pauses. And that's a cycle. And we usually do 5 cycles at a time, which we call a set, and then repeat. So somewhere between 15 to 25 of these, or until the mucus clears. So at baseline for my patients who have these at home, I say minimum 2 to 4 times a day. It's lung physical therapy, helps keep your lungs at a nice place. When we get sick, we have to up the ante. So we're doing it maybe every 3 hours, every 4 hours. And that's one of the things for someone who has this at home. If you're all of a sudden needing more cough assist treatment, that may be a sign I should be coming to the hospital where someone is managing me a little bit closer and can do treatment more frequently. Usually we use pressures between 30 and 50 centimeters of water. and it blows in anywhere from 1.5 to 2.5 seconds. So it's pretty quick. Blows in, sucks out. So you can do 5 in about 30 seconds. It's not a big time eating therapy. And I tell people, end with the inhale, because if the air sucks out, then you're left with your chest collapsed down, you feel short of breath. So we always want to end with our lungs nice and blown up. Are any of you guys familiar with cough assist devices? It's something that is very unique to neuromuscular diseases. So actually, here in Pittsburgh, at even a few of the main sort of higher level of care hospitals, they don't even necessarily have them. So this is something that may not be available depending on where a patient is admitted for therapy, but always something worth asking for if mucus and secretions are a problem, because it is not a necessarily common thing for a doctor to know about or think about if you don't take care of the patients with the muscle weakness. We can also do manually assisted cough, which some patients prefer, which is essentially pushing and applying pressure to the diaphragm when the person is inhaling and then exhaling. So it can be done sort of placing the hands underneath the ribs on both sides from the front, so kind of like or some people, depending on their strength and positioning, will stand from behind and sort of pull up that way. You're basically trying to pull up under the ribs to pull that diaphragm. When you think of the picture we saw with how do we cough, you're trying to help that diaphragm be pushed up faster to help expel the air and the mucus. So what are some of the challenges that we have with getting admitted with respiratory illness? I looked for some cartoons to sort of describe what I think I've heard people say. The ICU is not a place where people want to be, not because you're being seen, but because you don't get much sleep in the hospital. And it is a high-stress place, stressful for families, stressful for patients if you need to be admitted, and even more so if you need to be in the ICU. And so it's something to know you need it and to be there, but to also recognize it's going to come with the stress that comes with it. And how do we manage that, and how do we help support the patient and the loved ones so that we're getting the best care and we know that things are being taken care of. So when I think of sort of my best tips and tricks for navigating acute illness, especially in my neuromuscular patients, and I told a handful of people I was coming to talk here at RYR1 conference, and they said, "What's RYR1?" I think anyone here sort of hears that a lot, and this reminds me of this. Somewhere along the way, someone might have heard it, but with everything they learned, it didn't make it to the front of the brain or the top of the brain or even in the brain, right? So knowing that and understanding that with unique things, whether it's RYR1 or it's somebody who has a different genetic disease or something, they all come with their own nuances, and there's a lot of literature that can be found on it, but you might have to be the advocate for yourself if you're the patient, for your loved ones, and not be afraid to have information, have it handy, and be able to share it with the people who are the providers. I think a doctor who's not willing to hear and learn from a patient about something they know more about is not doing the patient justice, right? There are many times, especially parents know their kids best, right? As a pediatrician, I always said, Mom and Dad knows best. They're there every single day. I only see the kid here and there. The same thing for people who have diseases that are not sort of your classic textbook high blood pressure, diabetes type things that are well known how to manage. So if you have a manual to yourself, don't feel afraid to share it or to explain, with this, I'm at risk for this, because people just don't know, and the knowledge can really, sharing that knowledge can help you along the way. So I think my tips and tricks list when I came up with it were, the prevention is really key. So trying to prevent acute respiratory illness with vaccines, with respiratory therapies, masks, avoiding people who are sick is key. Second, we're not going to go through the world and avoid it. So we have to just pay attention for any signs of illness, whether that's knowing your baseline heart rate and oxygen, how far you can pull an incentive spirometer, all these things we can do to make measurements and have an idea of what our body's telling us. Don't wait. Don't be afraid to seek some attention or at least just be evaluated early so that we can hopefully avoid the complications if we wait too long. Advocate for yourself. Share the information. What's RYR1? What does it mean? We can't have this or that. If we're on the ventilator, you need to make sure that the extubation happens a certain way so that you can survive it and get through it. Don't be afraid to ask questions. Why do you think I need this? Right? Not in a mean way, not in a like I don't trust you way, but in a I just want to learn more kind of way. Teach me, educate me. Why is this going to help me? Why is this going to help my loved one to get through this? And sharing the knowledge, having even a one piece of this is what RYR1 is. Are the big things that come along with it. When someone is sick, this is what can be expected. This is management. I know there's a good bit of that on the website, even for the RYR1 Foundation and so forth. So I think I stopped there to sort of allow room for time and questions. So hopefully this was helpful for you guys. So a small audience, who wants to go first? I'm supposed to give you the microphone so that it's being recorded so people can know what's being asked.
So at night, I'm the worst sleeper in the world. I wake up about 8 to 10 times a night. But on the rare occasion that I do sleep, where I have like 4 hours sleep, when I wake up, I've got the thickest head, and I'm like really cloudy for hours after, because I'm assuming I'm not breathing properly, or my husband sometimes says he prods me because he thinks that I'm not even breathing. So I do like sort of elevate myself a bit now. Mm-hmm. And also I have like really bad, when that happens, I have really bad pain all here. So I didn't know if you could.
Yeah, I can. In the afternoon session that is hypoventilation, my part, I'm actually going to talk a lot more on the sleep and breathing side of things, so that whether you can join or you can listen later on, that will give you probably a lot more in-depth answers than I'm going to answer now. But yeah, so the biggest risk with muscle weakness, I mentioned at the beginning, is the first step is we have trouble in sleep. So sometimes people don't even have symptoms that they're shallow breathing, but as the breathing becomes a little more shallow, people wake up more often, not feeling rested, headaches in the morning that clear after an hour or two by themselves, napping, daytime sleepiness. These are all kind of signs that maybe overnight we're not able to take as big a breath. In the acute setting, that puts you a little bit more at risk because you're sort of starting, at a different point that you're more susceptible to not being able to breathe as deep, potentially, if we have a sleep-related problem to start with. From a management standpoint, that's sort of the afternoon talk too, is how do we work it up? What kind of testing can we do? Oxygen testing, sleep testing. And the positive pressure that I mentioned, the BiPAP with the mask, etc., can be used and helpful on an everyday basis, as well as when you have an acute respiratory infection or something. So many times, if we can get people to breathe better at night, they feel better in the day, there's less susceptibility to being sick and illness, and a higher threshold to handle sickness. Does that answer your question?
Yeah. So is your talk this afternoon in the big room?
I haven't looked what room. It's called hypoventilation. It's at 2 o'clock, I think.
2:30.
Yeah. It's Dr. Meyer and myself. We're sort of hitting the ped side and the adult side together. Yep. How about other questions?
Yes, well, it's more of a statement. I just wanted to talk about how you talked about being an advocate for yourself. Um, I fully believe in that. My daughter is Brittany. Um, She is hypercapnic, uses oxygen, but we can only use, I mean, there's a fine line because oxygen will,
Make it worse.
yeah, put her carbon dioxide, oxygen in overdrive. So, but I can't tell you how many times we've been to the emergency room and I have had to demand, I have had to order an ABG for her because they were like, oh no, she doesn't need that, she's fine. Because the O2 sats, from the
Look
regular
okay.
blood work looked fine. I'm like, no, she needs an ABG. Trust me, she needs an ABG. Look at her nasal flaring, chest rocking. She needs an ABG. Just please do an ABG. So I guess just to shut me up, they do an ABG, and every single time she ends up in ICU. I'm like, I know my child. So, like you said, every parent knows their child. A lot of times we end up educating them. They look at us, they see one thing, but you know your child, you know the condition. So a lot of times we really do have to advocate for ourselves to get what we need.
Absolutely.
So, yes.
I think those are great points. And for some of my patients, I actually have a sheet I made up with here is what you need to know about so-and-so, whatever their name is. And it includes things like that. If you give me oxygen, I'm at risk of my carbon dioxide going up. If I come to the emergency room, don't just put oxygen on me. Please check a blood gas. Make sure I have sort of a template of things I can pick and choose and then provide to each patient more individualized. So that can come from you as the parent, or a family or a patient can make their own. If you have a physician who understands and knows and is willing to sign off on it, maybe it will be read a little bit or looked at a little bit stronger by some people. It should be fine, in my opinion, either way. Knowledge is knowledge. And I know, I hear what you're saying, and that's my advocacy. Be nice, be strong, but you know best. Make sure that you're not yelling at someone, but nicely saying, please, can we do this? It's important. This is the history. Look in the chart, if it's somewhere that a patient has been before and been through similar things. Yeah. Other questions? Yeah.
I don't have a question, but I'd just like to say, the statement you made about all the cookies cannot be cut by a cookie cutter, we need to remember that, because even though we may have the same diagnosis, each individual is different.
Absolutely.
And that makes a big difference when you're trying to, render the service that an individual need, because you just need to know that all cookies can't be made by a cookie cutter.
I agree.
They're not the same.
100%.
Just a question about viruses. And, my understanding is that there are, early onset of a virus, it's possible to take some kind of medications to reduce the impact of the virus, make it less sick. My family, we get hay fever, we get viruses, general. And so how do you know, what's the timing of it? How do you know that this antivirus is the right thing for you? I mean, how's that work?
So that's a great question without a cookie cutter answer. So There are not an antivirus medication for everything. There's really a few. Flu being one of them, Tamiflu, kind of a common treatment for that. With COVID, we came up with Paxlovid and a few other things. There's some other viruses that have some treatments. All in all, they are not an antibiotic the way a bacterial infection gets treated and eliminates it. It's more of a, like you said, sort of decrease the severity, try to help your body keep from getting the worst of the symptoms. But you're right, it's sort of, most of them, and from COVID, I think it's probably the best example, within 48 hours of symptoms, starting medication. So the home tests are great for that. If the amount of virus is high enough, even the home tests that do flu, COVID, RSV can be picked up within the first day of symptoms. And most providers are willing, that I know at least, are willing, if you call and say I did a home test and I'm positive for the flu, of sending Tamiflu in. Or the tricky part is risk benefits of the side effects, especially when I think of Paxlovid and COVID treatments. That's sort of the one, every time someone calls and says I have COVID, I weigh. It's a lot of interactions with other medicines, so that is one negative. With using some of these antiviral medications. The other question is the side effects of it, besides the medication interaction, can sometimes make people feel worse. But you can't predict what the virus is going to do. So I sort of look at every person as an individual situation and each round different. So if there are very severe symptoms from the beginning, high fever, immediate shortness of breath, etc., I think it's probably more on the beneficial side to use medications. If symptoms seem kind of mild, then sometimes it's the risk-benefit of just letting the body fight it, with supportive things in the way of cough and clearance and staying hydrated and nutrition. So I just finished a week in the hospital taking care of our pulmonary patients this morning, actually, and I have someone with a trach with very severe muscle weakness that got COVID a week ago, and we went through this exact, what should we do? The symptoms were headache, tiredness, a little bit of mucus, but the chest x-ray looked good, the oxygen was good, and so we elected not to do the medicine for the risk benefit and the side effects. Had it been a different picture, I might have said do it. So there's no like perfect answer or cookie cutter answer, as we're talking cookie cutters. For this, I think each situation varies a little bit.
Thank you.
For sure. But the treatments for hay fever, like or allergies, nasal sprays, I didn't mention that in the acute side, but it does fit. Nasal sprays, Mucinex, cough medicines, they can be helpful in some of the symptom management, whether it's virus or allergies too. And decreasing mucus and clearance, it makes it easier, so, yeah. Other questions? All right. Thank you guys for joining. I think we're right on time for lunch.